my colleagues. I hope all of you enjoy this especially selective cases. Uh, I'm trying as much as possible to simulate the exam scenario, but with some addition, especially the atypical scenarios like this. I'm trying to cover as much as possible any unexpected scenario to save your site and hopefully to يعني, help you to pass FRCR to be Viva hot seat. This is our second session of mixed cases at our honorable group. Let's start our first candidate. Are you ready?
Yes, sir.
Could you request the control, please?
Yes. Can I scroll?
Request. You didn't request it.
Yeah. Can I request the remote control, sir?
Yeah, request. 7-year-old male patient presented with left shoulder and arm weakness and flaccidity with decreased mobility and sensation. Go on.
Okay. I'm presented with sagittal T2 weighted images for 17 years old, I think.
7-year-old.
7 years old patient complaining of left shoulder weakness. I'm scrolling through the images from the first cut to the end cut. I can't see any obvious pathology. The cord appears normal, no intramedullary hyperintense or focal lesions. The cervicomedullary junction appears normal. I can see here the exit foramina appears slightly widened. Can I take the other sequences, sir?
Which sequence do you prefer, doctor?
Axial T2, if I can.
Leave the mouse.
Okay.
This is axial T2. Go on.
Yeah, I'm scrolling now. Okay, I can see an extradural hyperintensity extending from the upper thoracic.
Where is doctor? Where?
This one.
Yes. And what else? Or in the sagittal, where did you find your pathology? Which region? No, don't use it again. Which region?
That's the exit neural foramina.
Where in dorsal or in cervical?
I think it's in the cervical region.
Okay, so look in the axial, in the cervical. Up, again. Yes, what happened here? The cervical. What happened? What happened?
Okay, this is the region of interest. I see it in the
Mm.
cervical.
Yes, what happened?
It's look likely widening of the
In the mouse. Deep. Look at this, please. Look here. What happened? Look here. What happened?
cerviginous like.
Okay. Right. Look here again. What is that? يعني when I give you one sequence, I'm trying to help you. So you must tell me the name of sequence. Yeah. What
This is
happened
the
here?
corona digital T2.
Okay, what happened here?
I can see a well-defined rounded hyper-intense signal intensity seen
Okay.
at the left-sided exit neural foramina at the cervical
Okay.
region.
So what's your differential diagnosis? In a
Uh, uh,
child has a neurological abnormality in the left side. He has a abnormality, neurological abnormality in the left side. So what's your differential
okay.
diagnosis?
Uh, I'm thinking about spinal meningeal cysts. Uh,
Okay. If I
uh,
told you this baby has a birth trauma, has a birth
uh,
trauma.
a
Look here.
pseudomeningeal.
Excellent. Look here. This is the exiting nerve root. Where is
Yeah.
the exiting nerve root here? Could you detect it?
No.
No. Excellent. And it is يعني replaced or occupying by dilated. What is this?
Yes. A CSF space.
Okay. So what's your final diagnosis?
Left-sided multi-level pseudomeningeal, likely related to the birth trauma the child had.
Okay. This pseudomeningeal, if I show you this, because see, there are some important related findings, but not
I
in
can see an ventral multi-level hypointense signal
where
uh, at the anterior, at the ventral side of the subdural space. I think it's a superficial siderosis that's
don't worry
killing
about
this.
it. See here, see at the left side, what is this? What happened for the muscle here? Here, what happened here? Compare left by right. This is almost, I think this is a supraspinatus. What happened here compared to here? This is,
Okay,
where
this
is
is
the,
high. I think it's the child going to have a muscle atrophy.
excellent, excellent. So conclude,
Uh,
please.
uh, a
See,
conclusion.
see what
Uh,
happened here. What
yeah,
happened here?
yes.
Compare, and compared to the contralateral side. What happened here? What is the name of this
Yes.
pathology?
Fatty infiltration or atrophy.
Excellent.
Uh,
Could you please
uh,
conclude? See, by the way, the case is not easy,
yeah,
frankly.
I can see.
Okay,
Yeah,
but you did very well. But conclude what happened in the left side, this pseudomeningeal cell, and the
it's
patient has a birth
the
trauma. Yes,
yes. I can tell that the patient have a multi-level left-sided cervical pseudomeningeal
yes,
with
this pseudomeningeal cell. What is the origin of the pathology? What is the name of pathology? What happened here? Huh? You see pseudomeningeal cell without nerve roots, without intact nerve roots. So what is the name here? Or what is the type of injury? Which part here has been injured?
brachial plexus. You mean here?
Yes. So yeah, give me final diagnosis. This is
Brachial
uh,
plexus injured, left-sided brachial plexus injured,
associated
and
with
brought
fatty atrophy of.
avulsion of the left shoulder girder muscles.
Thank you, doctor, so much. You did very well. It's not an easy case, but see,
Mhm.
my doctors, this is one case scenario, atypical, especially because the patient is 7 years old, and many examiner will not give you a leading history. Sometimes, if he give you this patient has birth trauma, and he has left-sided shoulder flaccidity and the motor abnormality, like this, he will yeah, disclose most of the answer, but sometimes give you shoulder pain, like this. Okay, if you did very well when you pick up here some changes here. cystic changes related to the foramen. Okay, very good. In comparison to the contralateral side is normal. So you ask for other sequences. Take care, my colleagues, this is lymph nodes. Okay, and very confusing here. Okay, yeah, the mistake you did, you are searching in the dorsal. You are searching in the, until I told you, doctor, where is the pathology that you detect in sagittal? Okay, the pathology in the cervical region. So you should concentrate in cervical region. Compare left with right, my colleagues. Sorry. Compare left with right. There are at least cystic dilatation associated with dilated foramina. Okay. And at least if you couldn't detect here the nerve, really it is very difficult. Ask for others. Ask for other sequences. Look here. Look here. This one. For example, this is the nerve. This is the nerve. Here, no nerve. Only cystic CSF space connected with the arachnoid space of the spinal cord. Okay, so you should give a list of differential diagnosis, include lateral meningocele, accept it. Then ask the examiner, this baby have a birth trauma? If the examiner is sure will tell you if there are birth trauma. Yes. Okay, doctor, I doubt here some neurological injury, avulsion of the nerve root, at least brachial plexus bursa injury. Okay, I bring this case to show how you shouldn't satisfy of search. See here, there are some signal abnormality here on comparison to the contralateral side. Also, there are fatty atrophy here, very obvious. I think this is very obvious. So there are supraspinatus and the subscapularis muscle fatty atrophy due to chronic denervation. Thank you, doctor, so much. Next candidate. Next candidate.
Yes, doctor.
Welcome. With control.
Okay. I requested.
Okay. 60-year-old 60-year-old female patient presented with abdominal distension and chronic constipation.
Okay, I'm presented with CT abdomen and pelvis, post-contrast axial cuts for a skeletally mature patient. I'm scrolling through the study.
Okay.
The striking abnormality is dilated large bowel loops with retained fecal matter. I'm scrolling to the end of the pelvis, searching for any transition zone. I'm tracing the bowel loops. I can see that the large bowel is distended till the end at the rectum.
Are you sure?
I'm trying to scroll.
Stop here. Stop here. What happened?
Here.
Go down again. Go down. Go down.
I'm suspecting that there is a swirl here.
Not a swirl, but there are a change of
Caliber.
Yes, go down again. Go down. Go down. Okay. So that where is the change of caliber? What is the
Here.
name of this region? Okay. I will help you.
At the
Leave the mouse.
rectosigmoid junction.
Excellent. I will help you again. Leave the mouse. Leave.
Okay.
Leave. Look here. What happened?
There is circumferential mural thickening with upstream dilatation of the descending colon.
Okay. And where is the point of transition?
Here at the rectosigmoid.
Okay. What else? What's your differential diagnosis? By the way, this is chronic, chronic for long time.
maybe a ischemic stricture
What else?
or diverticular disease, but I can see diverticular stricture
What else?
or colon cancer, sigmoid cancer.
Would you detect any of this? You give me a list, but is this list related to our case? Could you focus on this slice, especially what happened? What happened here? What is the name? Oh, stop, stop. What
Okay.
is the name of this area? Area above it, markedly dilated sigmoid colon, and below it, collapsed rectum.
Transition zone.
Okay. Okay. What do you expect? It is a typical case, by the way. To make it more.
Maybe fecal infection and the colitis.
No. What else? If I told you this is since very early, it is related to childhood.
I can see abnormal configuration of the coccyx as well.
Okay. But concentrate here.
Okay.
If I told you this is a ganglionic segment, so what's your differential diagnosis?
Hirschsprung disease since childhood.
Yes, yes, adult Hirschsprung disease, and it looks like neglected. Okay, what else?
Okay.
This examination contain two very important pathology. I will not help you. What happened?
Yeah,
Hmm. What happened again in this examination?
I'm trying to scroll to figure out
No,
if there is
stop,
any
stop,
other.
please.
Okay.
Go back, go back.
Okay.
No, no, no,
Okay.
no, no.
Other
Opposite,
side. Okay.
opposite, other side. What happened here? Stop.
Okay.
What happened here?
I can see the
What?
standard full bladder.
Okay, and what else? There are very important pathology here. What happened here? No,
No, I can catch the pathology.
what is this? What happened to the right kidney, Dr. Liz? No, no,
Can I scroll?
yes. What happened to the right kidney, please? Could you tell me? What happened?
Okay, I'm trying to
Both
scroll
kidney.
again. Okay.
Yes, yes. Allah,
Okay.
see. Look at both kidney, please.
Oh,
Let me help you. Look
okay.
here. What happened to the right kidney? Here.
Hydronephrosis, right hydronephrosis.
Okay. And to the left also.
The same, right? Left hydronephrosis.
What is the cause?
Ureters are implicated in this thickening.
Yes. Yes. Excellent. Thank you, doctor, so much. The case is
Thank you.
also difficult and
Thank you.
a typical scenario. And my colleagues, I'm trying to help you to collect as much as possible a typical scenario to cover any emergency in your exam. Okay. What happened here? Markedly dilated. You did very well until before the end. Markedly dilated, and then caliber change. Here, see, all the vowel, not only the colon. I think you can't even differentiate where is the small vowel. I think this is maybe the small vowel. Markedly dilated colon loaded by feces, and then here there are significant caliber changes. So at least the pathology is here. So ask the examiner to give you any other, either coronal, sagittal. This is a sagittal. What happened here? Funneling. And then this is the point of transition. Marked dilatation of the sigmoid colon, the complete collapse of the rectum. Is there are any mechanical obstruction here? No. Is there are any obstruction from outside? No. So the pathology is from the wall itself. The wall itself. Could you detect any mural mass? Frankly, no. See, all the rectum is homogeneous in thickness. So at least keep in mind it may be something neuronal. If you told the examiner, oh, okay, it may be a mural mass, but I told you this is chronic. So if you told the examiner it may be a ganglionic segment, doctor, I suspect an adult Hirschsprung disease, but it is very rare. Okay, the examiner will be happy so much. Then I ask you what happened here. There are very obvious pathology. Why we didn't look at the bone? It is very classic bamboo shape. Correct? Very classic bamboo shape. Okay, my colleagues, this case, especially my colleagues, is a very typical long case scenario. Especially, he will bring you something like this. Okay, for differential diagnosis, and take care from site finding. It's very important. One, this is bamboo shape, MS. Okay, we will also confirm in the coronal. I think here I couldn't, the sacroiliac joint completely fused. And all the bones are abnormal, by the way. I think also this patient, due to this bilateral, okay, hydronephrosis, he may have some sort of renal impairment. But however, here I could detect in the delayed one, some excretion or good excretion, really. Okay, there are excretion here, moderate at least hydronephrosis. So this is an adult Hirschsprung disease associated with ankylosing spondylitis. The Hirschsprung disease complicated by bilateral hydronephrosis. Thank you, doctor, so much. Next candidate.
Yes, sir.
Welcome. Would you ask for control, please?
Yes, sir. I have asked.
Yeah. This patient post-motor cyclic accident. One second. Oh, my colleagues, there are somebody who add some annotation. Please don't use the annotation, please. Again, request again, doctor.
Yes, sir. I'm requesting. I have requested, sir.
Okay, go on. I will help you.
I have been provided with the axial CT images of an neck region.
See. If you can scroll by the arrows or by the wheel of mouse, okay, any of them.
Okay, I'm trying, sir.
See, I will put here. Leave the mouse. I will put here. Leave the mouse. Yeah, you can use the arrows up and down, up and down. Go. Working.
No, sir, it's not.
Working.
Okay, I think it's working. I think.
Let me scroll for you to save time. Let me.
Okay, I have been provided with the axial CT images of an head and neck region. Bone window. Here I can see that there is evidence of a significant emphysematous changes are noted within the both side of the neck region, within the muscle compartment.
What do you mean? What do you mean by emphysema dissection?
The foci of air noted within the
Or
region of the neck.
or you mean surgical emphysema?
Yes, yes.
Okay.
Um, and I have to look for the vessels if there is any, if there is a injury. So I have to look vessel if there is any evidence of aortic dissection.
Huh?
I'm looking the carotid vessels. Carotid vessels. I'm scrolling down. And the right vertebral artery appears narrow in caliber.
Okay. But it is
And
normal variant. Normal variant. Don't worry about it. What
okay.
else?
I'm looking at the carotid vessels. I The carotid vessels appears normal.
Yes. What else?
Okay. Now I have to look the bones if there is any evidence of fracture.
Okay.
On
Go
the
on.
bone, I can see there is evidence of spinal bifida at the posterior aspect to certain vertebral level, and there is a right transverse process fracture is noted on the. In my routine practice, I will look the sagittal image, which vertebral body is this, and there is a
Okay.
fracture on the right side of the transverse process. I have been provided with the sagittal images of an neck bone window. Here, there is evidence of just over here. Sorry. Sir, can you stop there? Yeah. See. There is evidence of a fracture noted at the region of the C7 vertebral body at just a superior corner.
Yes.
Can you? I want to see the facet joint if there is any evidence of facet dislocation or any perched on the facet joint appears on the normal. I would like to see the on the other side of the. Uh,
What happened here?
sorry.
What happened here? Tell me. The key
Okay.
here.
I'm looking the spine. I could not in this given image. I could not find
What else?
the looking at the if there is. I have to look for if there is any evidence of atlantoaxial dislocation or occipito axial dissociation. I would like to see if there is an increased distance between the occipital condyle and the odontoid.
No problem. It is intact. What happened? See, I stopped when the examiner stopped one slice. He not joke. What he want is in this slice, and he wanted to save time, or he wanted to guide you. The pathology here, the most important pathology for me, or for this case, is in this slice. What
Uh,
happened?
okay, I can see there is some retropharyngeal soft tissue thickening is noted. Uh,
Okay. What else?
and these are the thyroid cartilage which appears to be injured. I have to look again the axial images if they are injured.
What happened again, Dr. Akila, again? What happened? Yes. What happened for the thyroid cartilage? Tell
These
me.
appears to be a fractured and
Thank you, Dr. Akila. You did very, very well. Thank you so much. This is
sir,
the trick.
I'm Roshni. Sorry.
Sorry, Dr. Arishni. Sorry. Uh, your voices is looks like each other. Sorry, Dr. Roshni, you did very well. And your style is amazing. My colleagues يعني remember her style. She she talk and she يعني comment on each part of the spine, including the facet joint, atlantoaxial, and she start with the most critical part by the arteries. Really, very, very interesting style of description. And finally, and it is very difficult. She pick up this very difficult finding. There are thyroid cartilage fracture. Very important to be mentioned because it is related to the larynx, related to inspiration, expiration. Very important. Besides that, see, there are many minor findings like this fracture. Okay, there are fractures, but the patient will not die from this very minor corner fracture. Okay. Second, what is you forget something important. What is this? Some oropharyngeal foreign bodies, multiple, maybe broken teeth, maybe something else. Okay. And you forget to tell me there are not a nasal, 80 tube. You must comment. Okay, but overall, thank you very much, Dr. Roshni. You did very well. This is the thyroid cartilage fracture, my colleagues. This one. Also, there are extensive surgical emphysema of the neck. See, look here, my colleagues, at these foreign bodies, there are multiple foreign bodies. Thank you, doctor, so much. One of the very important cases. Next
Thank you, sir.
candidate. It is, by the way, bilateral. Bilateral, see, bilateral thyroid cartilage fracture. Here, fracture, and here, and look at the left side, fracture. Thank you, Dr. Roshni, so much. Amazing. Next candidate.
Yes,
Next
sir.
candidate.
Good evening. Good evening, sir. Candidate for
Good
here.
evening. Welcome, doctor.
Yes, sir.
45-year-old female patient presented with bilateral lower limb weakness.
Okay. I have requested for the control, sir.
Yes, yes, go on.
Okay. So, okay, this is the scanogram of the patient of a patient presented with lower limb weakness. Talking from above, there is some haziness, opacity is noted in the left lower zone of lung, which could be a consolidation. I will, in my routine practice, I will zoom the image to see it clearly. Apart from that, tracheobronchial branching is normal and right lung is normal. There is no costophrenic angles are clear, no effusion, and bony cage in the chest appears unremarkable. In the coming to abdomen, liver shadow is normal. There are some gaseous distension of the bowel, noted mostly in the central part, which appear to be distension of the small bowel. However, there is paucity of gas in the pelvic region, otherwise unremarkable.
Breathe,
Yeah,
concentrate in the lung. Concentrate in the lung.
Oh, okay. Sir. Apart from that, sir, can I zoom little bit?
It is very clear.
In the lungs, sir, also I noticed that there is slight mediastinal shift to the right side with slight widening of the mediastinum in the in the superior part.
This is projection.
Okay.
Projection.
Okay.
Projection.
And cardiac outline is normal, but however the opacity is slightly silhouetting the left heart border. So this is in this could be in the this could be in the means lower. This could be in the anterior lower lobe. This could be still in the lower lobe, and however the diaphragm is not silhouetted.
What happened for both lung? What type of pathology here in this scout?
This area of dense opacity, I am thinking of consolidation, sir.
Okay, but here, leave the mouse. What happened here? What happened? Is this normal for you? This normal?
No, sir. No, sir. Otherwise, also bilateral lung has some granular, reticular opacities are noted in both lung, and especially more on the left upper zone also.
Okay, this is something more than granularity. This is annularity.
This appears to be reticular with some possible small cystic areas within it. This pattern could
What
be
will you do next,
like
doctor?
Sir, for this, I will suggest for CT scan of the chest, HRCT, for further evaluation of the possible cystic lungs disease.
But as the patient has a bilateral lower limb pain, his clinician ordered this examination. Yes.
Okay. In the this is the bone window, and here I noticed that there is a any history of trauma was there, sir? No. So I noticed there is a collapsed vertebral body in the mid thoracic vertebra. With also there is some collapse on the upper aspect of the lower of the descent lower one, with the fragments propulsing into the spinal canal, and possibly
And
there is a compression of the cord also. I'm looking
yes,
at so in this for this finding, I'll definitely urgently
you
plan
can
for an
scroll,
MRI.
doctor. Doctor,
Okay,
you can
yes, sir. Yeah,
scroll.
yeah, yeah, yes,
Scroll,
sir.
please.
Yeah, yeah, yes. Hmm. Okay, so yeah, yeah, it's moving, sir, now. So getting some red blocked area is coming, sir. Red stop area.
Leave the mouse, leave the mouse. Leave,
Hmm.
leave. You tell
So
me what happened here.
yeah, yeah, sir. Apart from that, I noticed that there is an abnormal area of hyperdensity within the substance of cord. This could be due to even hemorrhage within the substance of cord in that area. So retropulsion of multiple fragments due to fractured vertebral segment and with cord injury. Also, this happened also in the entry aspect in the
Look
prevertebral
here,
area
please,
also.
doctor. Look here.
Hmm.
Here.
Okay. Uh, here yeah.
What happened?
Though there is also prevertebral soft tissue, prevertebral collection is noted with along with the fragments and
Okay.
prevertebral, yeah, and as cord injury I already told. Apart from that, in the lungs also I can see that there is a multiple interstitial thickening is noted in the diffusely and with some nodularity in the both sides of lung.
Okay. What's your
Uh,
final
so
diagnosis?
so sir, whether it was traumatic or pathologic, I mean, any history of trauma?
No, any other history.
Okay,
This is
no, no,
enough.
no trauma. Okay, yeah, okay. So yeah, with the so in this background with lung having multiple nodular miliary like shadowing, and also with the prevertebral collection and collapse of the vertebra and lower limb weakness, I am thinking of some possibility of this being spinal tuberculosis, discovertebral infective tuberculosis due to infective discovertebral segment due to
What will you
tuberculosis
do
with
next?
adjacent lung changes.
What will
Sir,
you do
I will
next?
correlate. I will correlate. I will suggest for the lab parameters and also gold spot test, and also for the if the findings are positive, then I will inform the community center for the contact tracing and also for community referral. Also, follow up should be required for this case. This spine MRI should be definitely done. MRI of the spine with contrast.
Thank you, doctor, so much. Did very well. Please, my
Yeah,
colleagues,
yeah. Thank you.
TB is
Sir.
very
Thank you, sir.
common. Is very common. You must face one case of TB.
Hmm.
I think in my Vivas trial,
Hmm.
I face at least one case. Okay. Second, the
Hmm.
examiner
Hmm.
didn't inform you about any history other than bilateral lower limb weakness. Bilateral
Weakness, yes.
lower limb weakness. So I think yeah, you can understand there are no trauma. Okay.
Okay.
Then
Yes.
here,
Yes.
here, see, there are some soft tissue thickening here. How could I
Hmm.
detect it? This air
Hmm.
column is completely obliterated and
Hmm.
forward displaced. Complete fragmentation
Hmm.
here. Okay, see?
Hmm.
And from the scout, this is not a granularity, and the lung is not normal. This is miliary TB from the scout.
Okay.
My colleagues, when you
Okay.
face
Hmm.
a scout or X-ray like this, both TB,
Hmm.
miliary TB, even not
Hmm.
TB, on the top of your differential diagnosis list, the examiner will not unhappy at all, even if it is not TB. But like this, you are a
Hmm.
safe radio. Second,
Hmm. Hmm.
okay, you can put miliary metastasis like this, no problem. But at least this is a miliary nodules, extensive and innumerable tiny nodules in both lung. Second, here there are a pre-vertebral and
Hmm.
intraspinal extension. This is very critical, very critical. Take care, my colleagues,
Hmm.
from this minor mistakes,
Hmm.
but
Hmm.
critical.
Hmm.
Second, don't neglect anything that the examiner will show you. I select this especially not for spine, but for lung. Despite this is a not lung examination. Okay. Third, you forget to tell me I will isolate the patient. Why? Because this is a miliary
Yes.
TB. Miliary
Yes.
TB
Active disease.
means highly
Active.
infectious.
Yes.
Yes,
Active disease.
because it
Yes.
is active. Thank you, doctor, so much. Next
Yeah.
candidate.
Thank you, sir. Thank you, sir.
Welcome. Next
Hi
candidate.
there. Hi, doctor.
Hi. And could you ask the control, please?
Requesting control. Yes, I've requested remote control online. Yep.
This patient presented with left iliac fossa pain, acute pain.
Left iliac fossa pain. Okay, acute pain. I would like to scroll from top to bottom. I'm presented with abdominal thoracic. Okay, so I'm presented with thoracic and abdominal slices in the axial slices of the CT abdomen and thorax. Sorry, okay, there appears to be dextrocardia present. The heart apex is seen to the right apex. Just scrolling down. Okay, fine. The liver seems to be on the left-hand side. The spleen is seen on the right-hand side. There appears to be situs inversus totalis. I'm looking for the stomach. The stomach appears to be, on the right-hand side. So I'm just scrolling through the images. And the pain was in the left iliac fossa. Okay. Looking at the bowel, there is no obstruction of the bowel. They're not grossly distended. Just looking at the small and large bowel, there's a bit of fecal loading. Looking at the attenuation of the bowel, there doesn't seem to be any ischemia or any
Leave the mouse. Leave the mouse.
Sorry.
Second, please.
Enhancing region.
Please go on. Yes.
Okay. Can I scroll? Sorry.
Yeah, go on. Please, my colleagues, mute yourself. 1 second, doctor, please.
Okay.
Yeah, go on. Go on.
Okay. I'm looking at the MRI of a.
Yeah. This is a CT. Go on.
Okay. Yeah. So CT. Sorry. Okay. Yeah. I'm just continuing to scroll. Okay. So currently, I'm just trying to look at the left iliac fossa. I can see some central dilated small bowel loops. There's no obstruction. Okay. I can see that there is thickening of the terminal ilium/cecum. Sorry, that's the cecum with the fat. So I'm just trying to orientate my anatomy. There appears to be a blind ending loop seen in the retrocecal region in the left iliac fossa, in keeping with the appendix, with surrounding periappendiceal fat stranding. No evidence of any appendicolith, no evidence of any free air or collection. However, it does appear to be thickened. No fistulous connection with the adjacent structures. Due to the location, and in a patient with situs inversus totalis, I would say this is in keeping with appendicitis. But other differentials that could also be in this location is a mental infarction or epiploic appendigitis. I don't see any other fat stranding anywhere else. There's no free fluid in the abdomen. I can't see any other features. So in summary, there's a patient with situs inversus totalis with acute appendicitis. I would like to review the lung and lung window. If there's a bronchiectasis of the lower lobes, then I'm concerned that this patient may
Leave them
also
out.
have syndrome.
Leave them
Okay,
out.
sorry.
Lung window for what?
For lung window, sorry.
Why? For what?
So if from memory, there appears to be situs inversus, but I just want to make sure there's no low bronchiectasis, because otherwise it could be a syndrome. I think
Tell you
it's
what.
cartigenous syndrome. But if there's no bronchiectasis, then I would
What
say
do you
this is
say?
just. Oh,
What do you
sorry.
say?
Yeah, looking at the lungs, there's general emphysema of the lungs, but looking at the bronchi in particular, there is mild calcification peripherally of the bronchioles and thickening. There's signet ring sign present as well. So there is low bronchiectasis in place of this patient. Yeah. So in summary, there is low bronchiectasis in keeping with situs inversus. I would also like to, the cartigenous syndrome is a triad. I can't remember the other feature, sorry.
Thank you, doctor, so much. Really, I'm so impressed and I'm so happy that you pick up this difficult case. This case is an example of you to how extent you should examine from top first slide to the last slide. See here, the key is not in the left iliac fossa, no, but the key here from the beginning, situs inversus totalis. Okay, situs inversus totalis. The key is here, very important. Second, when you change it to lung window, you pick up the bronchiectatic changes, and then when you pick up this localized fat infiltration or fat smudging surrounding an a blind-ended second hollow viscous. This one, appendicitis. So this is a case of appendicitis in Cartagena syndrome, situs inversus totalis. This is appendicitis, my colleagues, and you exclude all possible this until its step, all possible complication. Thank you, doctor, so much. I really am so impressed. Thank you.
Thank you.
Next candidate. Next candidate.
Sir, candidate 6 is not here, so I'll be doing the turn.
Okay, Romer, welcome.
Yes, sir.
This patient came for routine follow-up for hair eyes, and the hair ophthalmologist asked one MRI brain. Go
Okay,
on.
sir. I'm provided with the T1 axial section non-contrast images of a patient. I will first of all scroll till the top and then scroll down. So sulci and gyri and the gray white matter differentiation appears to be unremarkable. Bilateral ventricles are unremarkable. I can appreciate that there is an signal intensity, which is predominantly located in the scalp over the right temporal region. And then I will scroll down. I can see that the bilateral orbital cavities are unremarkable. There is mild kinking noted in the right optic nerve, which I would like to correlate and see on other images as well. I will scroll till the last section to see any other abnormality, which I cannot see. So I would like to correlate my findings with the post-contrast images and other T2 or as well.
Leave them out.
Yes, sir.
1 second. Not this. This one.
Okay,
Yes.
sir. So these are the orbital views, post-contrast images of the same patient. As I scroll down now, I can appreciate that there is enhancement noted in the region of the scalp, and this enhancement is continuous till the temporal region as well. And then I can appreciate that there is a cystic component also noted in this lesion as well. And now I would like to review the orbital cavities once again, and the
1 second. 1 second. Leave them out.
Okay, sir.
Leave. Yes. Go on.
Okay, so now I am provided with the T2 coronal images, and the diffuse scalp thickening is appearing hyper intense as seen previously. And now I would scroll from front to back, and parietal orbital cavities are grossly unremarkable. And then I can appreciate that there is some thickening noted along the right optic nerve, and
Okay. Okay.
uh, and yes, sir. So, summing up all my findings, I'm concerning for neurofibromatosis type 1, as I can appreciate that there is ultra muscular intensity area in the scalp, which could represent plexiform neurofibroma, and then this finding
Yes.
in the eye could represent or optic nerve glioma. I would examine rest of the brain to look for any area of facie or unobjectified bright object, and I will also examine the next of the neural axis to look for any other pathology in the spine, and I will also advise screening of the relatives for further workup.
And what would you want to exclude from a brain MRI in case of NF1?
Sir, optic nerve gliomas, then unidentified white objects, FASI, sir, and
Yes.
um
And
and
what
then
else? What else here? Here,
so
what
this is
else you want
plexiform.
to? Yeah.
Oh,
Yes. You didn't ask for detail, so he didn't give you. Yes. Thank you, Dr. Umair, so much.
okay,
A really
okay, thank
brilliant and ideal answer. This is a plexiform neurofibroma over the right temporal aspect, extending anteriorly. Compare right with left, right with left. Thickening here, okay, with some fluid level, okay, and it extends with the right preceptal orbital region. Okay, he remarked some kinking here and thickening, by the way, it is bilateral, not unilateral. So he asked for other sequence. So I give him bilateral. See, my colleagues, this is not normal. And also this one, down, down, up. See, until I think the chiasm also is bulky. So bilateral, at least optic glioma associated with right-sided
you.
plexiform neurofibroma. So two finding is enough in this case to diagnose NF1, and all of us know the list of management like screening of relative, DNA, like this. But you forget to tell me I wanted to exclude thalamic glioma. You did very well when you told me I wanted to exclude FASI. What is FASI, Dr. Umar?
Sir, focal unidentified white objects.
No, focal abnormal signal intensity.
Yes, okay, okay.
Okay, thank you so
Okay.
much, Dr. Umar. You did very, very well. Next candidate.
Thank you, sir.
Yes,
This patient
if
presented 50-year-old 50-year-old patient presented with a chest pain. Can you request the control?
okay, please, I requested the control. This patient is 15 years old or 50 years old?
50, sorry. 50-year-old
50
request 50. Request control, please.
request control.
If you don't know, no problem. Go on.
I don't know. Please, can you
Okay.
move it?
Yeah.
So I presented with MRI T1 study, scrolling from down to up, is finding that there is a mediastinal mass lesion. This is heterogeneous
Excellent.
mass, lobulated,
Yes.
right-sided, mainly, and extending beyond the esophagus.
Why
And
mainly, doctor?
between
Doctor, one.
now,
Why mainly right? This is completely right side.
yes,
Okay.
completely right-sided, and extension,
Okay. Yeah.
the mass extended in the anterior mediastinum to
Excellent.
the right, and it extending to the skeletal. It is likely causing destruction. It is also
What is this?
there is linear
Okay.
hypointensity at the base of the lung of likely pleural effusion.
Excellent.
I'm thinking about anterior mediastinal mass lesion like thymic tumor with invasion or other
Okay. What What sequence do you want?
unexpected lymphoma or teratoma. I'm sorry.
What next sequence do you want?
This sequence T1.
What other sequence do you want to see?
I take the other sequence. I would like to show the T2 also post-contrast study. In
Go on.
T2, it is the heterogeneous mass. It's
This
extending.
T2, doctor? No,
I'm
tell me
sorry.
what is the name of the sequence?
This is T2 sequence. There
Yeah.
is heterogeneous regulated
What
masses.
type of T2? Yani what type of T2 sequence?
T2 stir.
Yeah, okay. So this is a stage.
Stir images.
Okay.
It is a fluid sensitive sequence. It is a high signal intensity heterogeneous signal extending to anterior hemothorax and causing
Excellent.
rib destruction. And
Okay.
there is also pleural effusion confirmed
Yes.
in T2.
Yes.
I couldn't find a significant lymphadenopathy, is larger in size or abnormal pathological configuration.
So your final diagnosis?
Maybe invasive thymoma.
Okay. If invasive thymoma, what do you want to exclude from this MRI?
I will ask about the patient history. If the patient has myasthenia
No,
gravis or
no. From the MRI, what do you want to exclude? Look at the
I need
right
to
side. Yes. What do you want to exclude? Look at the pleura of the right and the left side. Is there are any metastasis?
no, it not looks at no nodularity seen in the pleural surface or significant pleural thickness. It is
Okay.
it looks like negative for invasion, but there is pleural effusion that is most probably suggesting extension to the pleura. But
Thank you, doctor. Thank you, doctor, so much. You did very well, especially when you told me there are some chest wall invasion. And this is the key in this case. Chest wall invasion differentiate malignant thymoma from benign thymic tumor. This is very critical. Second, you forget to tell me there are no any pleural metastasis because thymoma is very common. Malignant thymoma is very common to metastasize to the pleura. Very common. Very common, my colleagues. Take a home message, my colleagues. We must comment in the right-sided vessels, especially in post-contrast. You must ask the examiner, doctor, please give me sagittal, coronal, post, whatever, to rule out any invasion. See, it is abutting the superior vena cava. It is abutting it. So we must exclude any vascular invasion, either by any means, by any plan. I think here no obvious invasion. I couldn't detect. Look here. It is يعني attenuating. This is the superior vena cava. Okay. Okay. It is attenuating, slightly indenting, not slightly, indenting the superior vena cava, but no clue, no obvious clue of direct invasion. However, practically, we can't exclude any invasion here. But why? Do you know, doctor, why we can't exclude the invasion here? I will tell you.
invasion.
Yeah, for the vessels. See how long the contact between the tumor and the superior vena cava? Very long.
Okay. I can request for the patient upper limb venography for superior
Yes,
vena cava.
yes. This is very good suggestion. But we should inside the exam tell the examiner all what is in our mind. I think this patient may have some sort of invasion because see my colleagues, very long contact, and the indentation. The indentation in the thorax may be a sign of infiltration. Take care, my colleagues. Second point, as regarded to Dr. Khan, apartment of a malignant tumor to a vessel in the thorax. I'm speaking about the thorax, not the abdomen. for more than 90 degree, it is a sign of invasion. So we have many suspected sign of invasion here. We have two at least. Number one, this apartment at least is more than 150 degree. See, from here, my colleagues, from here up to here. This is about 180. Second, and this is very important details to be mentioned in the exam. See, very long apartment here. See, very long. I think all the length of the superior vena cava is indented by the tumor. Very long distance, contact distance. Number two, indentation. Number three, more than 90 degree abutment. I think this superior vena cava almost is invaded by the malignant thymoma. Thank you, doctor, so much. Take all this home message. It is very important notes. It can help you so much, all of you, within the hot Viva seat. Okay, my colleagues. Next candidate.
Yes, sir. I have been provided with the CT scan
One second.
abdomen.
One
Okay.
second.
Yes.
Request control first.
Okay.
Request. By the way, my colleagues, in the first few minutes of the Viva seats, especially in the first room, the examiner will try to speak with you for 1 or 2 minutes to break the ice. So this is very important. Speak with him. Answer his question. He will ask you, could you scroll well? Could you listen us? Hello, doctor. I'm doctor, and he will or she will tell her name. This is very important. And he will give you a very good smile. A smile also in his face in the camera. This personal contact, all of us are human. And all of us are affected with this indirect message. Okay, my colleagues, go on.
Okay.
This patient has severe abdominal pain. Go on.
Okay. I'm trying to scroll.
Leave the mouse.
Okay. Okay.
1 second, I will help you. See, you can use the arrows. Use the arrows. Okay, go on.
Okay. I'm trying.
Yeah.
Mm, okay. These are the axial sections of a CT scan abdomen and the portal venous phase. I'm scrolling from top to bottom. I can see multiple hypodense multiple hypodense lesions of variable sizes in both the right and left lobes of the liver. The lesion in the right lobe also shows some foci of calcification.
What else?
There are another striking abnormality is dilated bowel loops,
Yes.
loaded, showing fecal matter. The portal vein, pancreas appear unremarkable. There are two cystic lesions distant to the right kidney, likely renal cysts.
What else? Doctor, concentrate on the liver first and
Yes.
connect the data in the liver with this pouch and give me a considerable provisional diagnosis. I will give you, see, doctor, because this case
Yes,
is
yes.
very difficult. I will give you 1 minute scrolling because really it is difficult.
Right.
Concentrate in the liver. Yeah. Okay.
In the
About
liver,
30 seconds.
there are multiple hypodense lesions, variables
See,
of variable sizes in both
doctor,
lobes. Yes,
doctor,
yes.
take 30 seconds, examine
Right.
all the case because it is very difficult. And after that, tell me what happened.
I can see calcific density within the rectum. And the sigmoid colon. The small bowel loops are just fluid filled and mildly dilated, mainly dilated. The main dilatation is in the large bowel loops with fecal loading. I am trying to see the transition point.
So what's your differential? Give me any clue for the case. What are you thinking about, doctor?
I'm thinking about any lesion in
Stop here.
in the
Stop here.
bowel.
No.
Yes.
Go down, doc. Go down.
Yes.
What is this? Stop. What is this?
This is dense calcification in the rectum.
Okay, and proximal to it, what happened?
Dilatation.
So, and go up. What happened here in the liver?
These appear to be the cystic metastasis.
Okay, don't worry about these cystic lesions. What happened in the left lobe, my doctor?
There are air foci suggestive of pneumobilia.
Okay, so conclude. Give me a possible diagnosis. What is the name of this case, of this pathology? Pneumobilia, dilated bowel, and stone.
Gallstone ileus.
Okay, but this is rectal stone. Okay. Then look here.
Yes.
What is this?
Yes,
What
there
is
is fat
this?
stranding.
What is this? See? Look at the skin.
Yes.
See. Is just opening down, then scroll down. What is this track? What is the name of abnormal track between a bowel? Because this is a bowel and the skin.
Yes.
What is this?
This is fistula formation.
Okay, what type exactly? Fistula. Fistula between a
Fistula
bowel
between the colon
and
and the
skin.
skin.
Okay, excellent.
Intercutaneous fistula with adjacent
Okay.
fat stranding.
Okay, and if I
So this,
told you, see,
yes,
if I told you, see, this is the stomach. Go down to pick up the duodenum. This is the duodenum.
yes,
Pylorus, then duodenum. Go down. This is the duodenum. Okay,
yes.
concentrate on it. What happened between the duodenum and the colon here? What is this? Another track. So how many fistulas we have?
Yes, multiple.
2 fistula. Okay,
Yes.
duodenal-colonic fistula and
And
colo.
colo cutaneous.
Enterocutaneous fistula.
Intercutaneous fistula, yes.
Okay, thank you, doctor, so much. The tricky in this case, this incidental finding.
Okay.
As I told you before, see, doctor, it is very difficult, by the way, very difficult. But at least you should, from the beginning, told me, oh, doctor, there are pneumobilia and the dilated bowel. I will go down. Then you are telling me, doctor, I'm searching for a point of transition or transition point, and the stone in front of your eyes. Try, my colleagues, to tell the examiner what are you logically think about, because this is the point of transition, the stone, the impacted stone within the rectum. Okay, my colleagues. So this is a gallstone in the rectosigmoid colon, complicated by dilated bowel, pneumobilia, enterocolonic fistula, and enterocutaneous fistula. Very difficult case, but it may come in Viva, long cases, whatever. Thank you, doctor, so much.
Thank you.